Welcome back to Medical Review. Today, we are tackling one of the absolute biggest cases in all of medicine. I'm talking about a condition that's the leading cause of death, not just here, but worldwide. And you know what? We're going to approach it like a detective story, a real investigation where the main clue is one single, very alarming symptom: chest pain. All right, let's dive into this mystery. So, what is this deadly mystery we're talking about? Well, it's coronary artery disease. And I know you've heard of it, but today we're going to break it down piece by piece, clue by clue, so you really truly understand how we solve this thing. And our investigation, it always begins right here. Chest pain is that classic signal, right? It tells us something is wrong with the heart's plumbing, the coronary arteries. But here's the thing, this one clue can mean a whole lot of different things. So our very first job is to figure out exactly what we're dealing with. To get started, we've got to line up our suspects. Seeing coronary artery disease isn't just one single bad guy. No, it's a spectrum, a progression of disease that gets more and more dangerous the further along you go. So here it is, our official definition. It really all boils down to two key factors. First, how much of an artery is blocked, we call that the occlusion, and second, whether that blockage has actually started to cause permanent damage to the heart muscle itself. Now, think of this slide as our suspect board, okay? It lays out the entire progression of the disease. We start on the left with asymptomatic disease. This is where plaque is just quietly building up, no pain, nothing. But then things start to get a little noisy with stable angina. This is when a blockage of around 70% starts to cause predictable pain when you exert yourself, like climbing a flight of stairs. But the real alarm bells start ringing with unstable angina. At this point, the blockage is so severe you can feel that pain even when you're resting. This tells us the situation is becoming critical. And the last two stages, well, those are the full-blown heart attacks. An STEMI means heart muscle has actually started to die, something we can detect in the blood. But the most dangerous suspect of all, that's the STEMI, a 100% total blockage. This is a code red emergency, folks. And this, right here, really breaks down the core problem into two simple concepts. For most of this spectrum, we're dealing with demand ischemia. Think of it like your house having low water pressure. You can still get water, right? But if you try to take a shower and run the dishwasher at the same time, the demand is just too high and the flow slows to a trickle. If you lower the demand, say by turning off the dishwasher, things get better. The pain goes away with rest. But a STEMI? That's completely different. That's a supply ischemia problem. This is like the main water line to your house being completely severed. There is zero supply. It doesn't matter how little you demand. This is exactly why it's a full-blown emergency. So we know our suspects. Now, how do we start narrowing things down when a patient actually comes in with chest pain? Well, we begin by questioning them, and we have a very specific framework for that interrogation. It's called the Diamond classification, and you can think of this as our detective's toolkit for that initial interview. It helps us figure out the odds, the probability that this chest pain is the real deal, before we even run a single test. These are the three golden questions we ask to size up the situation. Question 1 is about location. Where is the pain? Real cardiac pain is typically substernal, right there under the breastbone. Question 2 is about triggers. What makes it worse? If exercise or exertion brings it on, that is a massive clue pointing to the heart. And question 3 is about relievers. What makes it better? If just resting or taking a tiny pill called nitroglycerin makes that pain vanish, well, that's almost like a confession from the heart itself. So the answers give us a score. If we get 3 yeses, that's typical angina, and we are on high alert. 2 out of 3 is atypical, and anything less than that probably means the chest pain is coming from somewhere else entirely. Of course, no good detective ignores the suspect's prior record, right? We also have to look at the patient's background for any known accomplices to heart disease. Things like a history of diabetes, smoking, high blood pressure, or high cholesterol, they all dramatically increase the risk. And a family history of early heart disease, or just getting older, are also major factors we have to consider in our case. All right, so once we have the patient's story, it's time. Time to head to the lab and analyze the physical evidence. And there's a very clear, very logical algorithm we follow to get our answers as quickly and as safely as we can. Okay, so in the ER, the number one rule is to rule out the most dangerous suspect first. So step 1 is always an EKG. We're looking for an immediate electrical clue, a specific pattern called ST segment elevation. If we see that, we've found our STEMI. Case closed. That patient goes straight to the cath lab. Now, if the EKG is electrically quiet, we move to step 2, checking the blood for biomarkers called troponins. These are basically proteins that leak out from dying heart cells. Think of them like chemical fingerprints left at the scene of the crime. If they're high, boom, we've found our STEMI. It's only if both of those tests, the electrical and the chemical, come back negative that we move on to step 3, a stress test. That's where we safely try to provoke the problem to see if we can catch it in the act. And for a STEMI, time is absolutely everything. This number you see here, it's critical. Door to balloon time. That means from the second that patient hits the door of the emergency room, the clock is ticking. We have 90 minutes max to get them to the catheterization lab and inflate a tiny balloon inside that blocked artery to get the blood flowing again. Every single minute counts. And here is a fantastic clinical pro tip for you. Troponins are great for diagnosing that first heart attack, but they hang around in the blood for days. So, what if a patient has a second heart attack just a day or two after the first? We can't use troponins again. They're still high. Instead, we check a different biomarker called CKMB, which rises and falls much, much more quickly. It's the perfect tool for that specific job. Now, back to that stress test. We've got a few options, and this table breaks them down perfectly. We need to do 2 things. We need to stress the heart, and we need to look at how it responds. The best way to stress it? Simple exercise on a treadmill. But if someone can't exercise, we use drugs to kind of simulate that stress. Now, how do we look? Well, we use an EKG if the patient's baseline electrical signal is nice and clear. But if their baseline EKG is already abnormal, trying to find changes is like trying to spot a tiny ripple in a stormy sea. It's just not going to work. In that case, we use an echocardiogram to literally watch the heart walls move. And for our most complex cases, like after bypass surgery, we'll use a nuclear scan to see which parts of the heart muscle are still alive and viable. Okay, we've identified the culprit. We know what kind of coronary artery disease we are up against. Now it is time to execute the plan. How do we actually treat it? For acute coronary syndromes, and that's our unstable angina, NSTEMI, and STEMI, we have a very famous mnemonic that guides our immediate actions. You probably heard of it. It's called MONA-BASH. The first part of our immediate response is MONA. M is for morphine, which we use for severe pain, but cautiously. O is for oxygen, and we only give it if the patient's oxygen levels are actually low. N is for nitrates. These are powerful drugs that help open up the arteries and relieve pain. And A is for aspirin. We give that right away to help stop the blood clot from getting any bigger. Okay, now stop. This is a life-saving warning. There is one specific situation where you absolutely do not give nitrates, and that's if the heart attack is affecting the right side of the heart. If you give nitrates then, you can cause a catastrophic drop in blood pressure. So why is that? Well, the right ventricle is what we call preload dependent, meaning it needs a lot of blood volume coming in to function properly. Nitrates open up all the veins in the body and basically steal that volume away, which in this case can be absolutely disastrous. Now for the second half of our mnemonic, BASH. These are more of the longer-term meds. B is for beta blockers, which slow the heart down and reduce its workload. A is for ACE inhibitors, which help protect the heart muscle from changing shape after an injury. S is for a statin to stabilize that plaque and lower cholesterol. And H is for heparin, a blood thinner we use in the hospital for NSTEMIs and STEMIs. And sometimes you'll see a C tacked on to the end. MONA, BASH, C. So what's the C? That C stands for clopidogrel, which is another powerful anti-clotting drug. It's absolutely essential for any patient who gets a stent placed in their artery. It helps prevent a new clot from forming right on top of it. So once we're in the cath lab, what's the big decision? It's usually whether to use a stent or to perform bypass surgery. Now, as a general rule, if only 1 or 2 arteries are blocked, we can usually prop them open with a tiny mesh tube called a stent. But if there's really extensive disease, like in 3 or more vessels, or a critical blockage in a major artery like the left main, then surgery to actually bypass the blockages is often the better, safer, long-term option. And that really brings our entire investigation full circle, doesn't it? If there is one thing, one core principle to take away from all of this, it's this. When someone comes in with chest pain, your entire process is designed to find or rule out the most lethal causes as fast as humanly possible. You start with a worst-case scenario, the STEMI, then you check for an NSTEMI, and then you work your way down the list. So there you have it. By following the clues, from the patient's story to the electrical signals on the EKG, to the chemical evidence in the lab, we can solve the mystery of chest pain and make sure every single patient gets exactly the right care at exactly the right time. The case is solved. And now the next time you hear about chest pain, you'll know the investigation has already begun.